So I have the honor of doing introductions for our first in our virtual series about the future of psychiatry. So today we're going to hear about advances in therapeutic neuromodulation. Unfortunately, Dr. Bennett is ill. Fortunately, though, Dr. Janicak has included some extra slides at the last minute in his presentation so that we'll have a well-rounded presentation. So Dr. Janicak will be our only presenter. We have no sponsors tonight, so I'm just going to go ahead and introduce Dr. Janicak. If you would, please hold questions until the Q&A portion. We will have plenty of time for questions and answers. As we're going through, if you think of something, though, feel free to put it in the chat. Dr. Jasleen Singh is going to be kind enough to moderate the Q&A portion of tonight for us. So she'll be monitoring the chat as the presentation progresses so that we can hopefully get as many questions as possible answered at the end. All right, so without further ado, Dr. Janicak is currently an adjunct professor and consultant to the Therapeutic Neuromodulation program at Northwestern University for the Department of Psychiatry, of course. Prior to that, he had a career in academics, being a professor at Rush, where he was the director of the Psychiatric Clinical Research and TMS Centers. He also developed and directed another TMS center at Linden Oaks Medical Group. So he's been doing TMS for a long time. He's conducted over 60 clinical trials. He's got over 500 publications to his name, including being the first author of the textbook Principles and Practice of Psychopharmacotherapy. He has served as the editor of the Psychopharm Review. He's currently on the editorial board of Current Psychiatry. He's been a reviewer for numerous other journals, and he has also won innumerable awards, including several awards from NAMI and also the IPS Educator of the Year Award. So Dr. Janicak has quite the lengthy pedigree and is very much a content expert in this area. Without further ado, Dr. Janicak will.
And unlike George Santos, I actually did some of those things. So we're going to be talking about advances in therapeutic neuromodulation. And the approach I'm going to take is to start with a little bit of information about ECT and some of the advances in ECT. Yes, even after 8 decades, we're still improving and refining that particular treatment, and do some comparing and contrasting to the other therapeutic neuromodulation approach, transcranial magnetic stimulation, which arguably is the most frequently used neuromodulation approach today. For example, there are about 600 ECT centers across the United States, and there are over 1,200 centers for TMS, so twice as many centers are available. And it's growing exponentially in terms of the availability. And did I have I didn't bring my slide up, I'm sorry. So that everybody can see that? Anybody hear me?
We can hear you, but we can't see it yet.
You can't see the screen?
Not yet. May just want to try hitting that share button again.
Yep, hold on, you're right. Now we're cooking.
Yeah, now we can see it.
All right. So some of the concepts I'd like to try to cover this evening are the definition of neuromodulation and give the perspective of it as an evolving therapeutic strategy, coming under the more general umbrella of interventional psychiatry, which incorporates neuromodulation, ketamine infusions, esketamine nasal infusions, psychedelic drug augmented psychotherapy, just to name a few. And we'll consider the application of neuromodulation for psychiatric disorders. And because of time, we'll focus primarily on major depression because that's where the lion's share of literature is. And in that context, I'll review the definitions, indications, efficacy, administration, and adverse effects of select neuromodulation approaches. And I'll do that all in one breath. So neuromodulation can be defined as the induction of electrical current in nervous tissue. Other terms that are sometimes used in the literature include neurostimulation or electroceuticals. So all the devices, all the treatments we'll be talking about today, in one way or another, accomplish this particular goal, and we'll talk about why in just a moment. It's based on the concept of functional disturbances in neuronal circuitry, for example, the cortical limbic mood circuit. And these circuits oftentimes not only intertwine with each other, but also move across long lines of connections in the brain. And there are 5 major networks which have an interconnectivity, which seems to be disrupted in people with psychiatric disorders, and particularly depression. Of the 3 that are of most interest based on neuroimaging studies and trials with transcranial magnetic stimulation, the salience network, the default mode network, and the central executive network are the ones that seem to be most disrupted during depression. And when TMS works, for example, or ACT works, or antidepressant drugs work, and patient resolves their symptoms, you can see a return to activity which would be consistent with someone who's not suffering from this particular issue. Another big difference with neuromodulation, in contrast to psychopharmacotherapy, is that it has episodic impact on the brain. So you're not bathing the brain in medications 24 hours a day, 7 days a week, indefinitely. You have maybe 6 to 12 ECT treatments given 3 times a week for 2 to 3 weeks, 2 to 4 weeks, or you have transcranial magnetic stimulation given daily, 5 days a week for up to 6 weeks. But in between, the patient is not receiving any other treatment, or they're taking medication for augmentation purposes, which we'll talk about in a while. As a result of that, the device-based therapies themselves have no sustained systemic effects. And that's a major advantage when you think about the tolerability and safety issues associated with many of the therapies that we have, and how many of our patients can't really benefit from treatment because of the tolerability issues. So that makes things a little bit easier for our patients. Neuromodulation techniques can be divided into different categories. The first one I would consider would be, is it an invasive procedure? And by that I mean, does it require a surgical procedure to be effective? And things like deep brain stimulation, vagus nerve stimulation are 2 common examples of that, with deep brain stimulation being approved for obsessive compulsive disorder, and vagus nerve stimulation for severe unremitting depression in the context of either unipolar or bipolar depression. The non-invasive ones can further be broken down into whether they require a seizure to get the therapeutic effect, or whether a seizure is not required. And that starts us with electroconvulsive therapy, which we'll summarize in just a moment, and something called magnetic seizure therapy. I don't know how many people have heard of this or read anything about it. It's investigational at this point, but we're moving in the direction of perhaps getting it into the clinic, and we'll talk a little bit more about what its advantages might be to electroconvulsive therapy. The 800-pound gorilla, as far as I'm concerned, in the room is transcranial magnetic stimulation, as the studies and the sophistication about using it and how it works are growing by leaps and bounds. It's been available since 2008, so that's going on 15 years for clinical practice. And as I mentioned earlier, there are multiple sites throughout the country at this juncture. Another approach is called transcranial direct current stimulation, or TDCS. And this actually has a larger literature and been around a lot longer than transcranial magnetic stimulation. But for a variety of reasons that we'll talk about when we consider this particular approach, it's never been cleared by the FDA, so it's only off-label that it can be used, or patients can actually go online and buy devices that are available without a prescription and treat themselves with it, or you can do it in conjunction with telemedicine. And we'll talk more about that in just a moment. And then I'm going to move into the future and talk a little bit about transcranial focused ultrasound stimulation. And this has a very intriguing approach and cuts through a lot of the problems we have with our existing neuromodulation strategies, and may in the not too distant future be one of the primary approaches we use in psychiatry. I'll make that argument. You can decide whether you agree or not. So let's start with electroconvulsive therapy. We have over 8 decades of clinical research experience with this particular treatment. That's the longest by far of any treatment we have in psychiatry, and one of the longest approaches in all of medicine. And there must be a reason that it's been around and still here. And the reasons are that it's often rapidly effective for more severe episodes of depression, which may not benefit from psychotherapy, medication, or their combination. These patients often have very serious side effects and very serious symptoms associated with their approach: psychosis, catatonia, high suicidality. There was a paper just published in JAMA Network Open about 3 months ago looking at the benefit in suicidal patients with ECT, and it was highly significantly favoring ECT over other treatments that it was compared to. Effective for various disorders, so not just unipolar depression, but also bipolar depression, mania, and schizophrenia. And as I mentioned earlier, like all the neuromodulation techniques, minimal systemic effects. However, the caveat there is to induce the seizure, one has to use an anesthetic procedure, and the anesthetic procedure incorporates several medications, which in and of themselves can cause side effects. So it's something to keep in mind, even though the treatment itself doesn't have systemic effects. One of the approaches required to provide that treatment does. There are a number of disadvantages to ECT. I start out with access, talk about ECT deserts. Back in 2008, I was a principal investigator for the pivotal study that led to the FDA clearance of the first transcranial magnetic stimulation machine. And as a result of that, invited to go to Albuquerque, New Mexico to present grand rounds on TMS to the Department of Psychiatry. And afterwards, they were kind enough to take me around their program and show me some of the activities they were involved in. And we got to the ECT program, and there were 25 patients waiting to get ECT, 25 patients. And I said, gosh, I didn't know Albuquerque had such a big population. And they said, oh, no. We don't just treat people from Albuquerque. We treat people from every other part of the state. We're the only ECT program in the state. Large swaths of Western Oklahoma and Western Texas, large swaths of Nevada and Arizona. And you can see these ECT deserts, especially out in the west, southwest, and far west, where there's just large areas. ECT is not even available. And so these patients had to travel many, many miles, get hotels, and get their treatments as quickly as possible at the one center that was available to them. So access to ECT is very problematic in many parts of the country. Patients' willingness to accept it and the stigma associated with it. There's so much in the literature about ECT. One Flew Over the Cuckoo's Nest, Ken Kesey's famous book, and the movie that followed with Jack Nicholson really gave a bad image of electroconvulsive therapy and portrayed it as being used as a punitive treatment as opposed to a helpful therapy for severe depression or psychosis. Optimal administration. There was a Blue Ribbon Committee that went to the Great Britain and in the United States and looked at the centers, mostly academic centers in both those countries that provided ECT, and found that only half those centers, and these are the academic programs that do it all the time and that provide ECT, oftentimes it's the only source in the area. Only about half the time do they deliver the electroconvulsive therapy and an optimal strategy. So even when, under the best of circumstances, we still have a lot to do to improve our ability to administer ECT. It's costly. It's typically $15,000 to $20,000, depending on who and where. That cost has come down more recently because, as I'm sure many of you are aware, where ECT was a hospital-based treatment for many decades. That's the way it was when I ran the ECT service at Loyola University back in the 1960s. Now, most patients may start inpatient, get a few treatments, and then finish their course in outpatient setting, or get it entirely on an outpatient setting, depending on their age, their medical conditions, their overall health. So the cost can come down substantially under those circumstances, dropping it into the $10,000 to $12,000 range. One of the big issues we have with ECT is, despite all the side effects associated with ECT and all the expense associated with it, is a substantial proportion of patients will relapse within the first 1 to 2 years after a successful acute course of electroconvulsive therapy. So relapse rates can be as high as 50% in some studies within 6 months after response to ECT. And then there are the adverse effects, of which the cognitive ones have been an important area to focus on. Typically, they're somewhat time related, and most patients recover but there'll be certain autobiographical memories and short-term memory loss which may never recover. There are multiple studies that indicate that this does not impair the patient's ability to function in their professional life, in their personal life, in their social life, but it does raise concerns about the memory issues. So a lot of the approaches that are trying to replace electroconvulsive therapy, like TMS, like magnetic seizure therapy, like FEAST, which we'll talk about as well, try to bypass or miss certain areas of the central nervous system, like the hippocampus, not running electrical current right through it, because the hippocampus, as many of you are, I'm sure, aware, is important for immediate recall and short-term memory. And so it's very disrupted in standard bitemporal bilateral ECT, and sometimes, depending on where you place the electrodes, with unilateral non-dominant ECT as well. I was doing real well up to then. Can't advance my slide. So I've alluded to magnetic seizure therapy, and we haven't talked about magnetic therapy yet, but think of it as transcranial magnetic stimulation on steroids. They use very large stimulating electrodes placed typically at the top of the head, as you can see in this particular picture that's provided. And it delivers a very intense magnetic field, sufficient in frequency and intensity to induce a seizure. And the idea is, of course, to put the patient to sleep with an anesthetic procedure, as we do with electroconvulsive therapy, but to run the current path and density, avoiding deeper cortical structures that are associated with memory, as I alluded to just a few moments ago. So the coil placement is over the vertex and frontal area, high frequency, 50 to 100 hertz, typically with ECT, we treat with with transcranial magnetic stimulation, we treat with 10 hertz, 100% machine intensity, stimulation trains of 2 to 20 seconds, anesthesia required, as we mentioned, a 2 to 3 week course, 6 to 8 treatments, and hearing protection. The whole focus of this particular treatment is, can you get the same benefit as you get with electroconvulsive therapy and avoid and minimize the cognitive deficits associated with ECT? And in a systematic review of 8 small studies, the total sample size was only 121. They reported remission rates of 30 to 40% and no cognitive adverse effects with magnetic seizure therapy. Predictors of response included fewer episodes of depression and a positive family history of response to ECT, and may be an effective maintenance strategy after a successful acute course of ECT. So as you know, if you work with patients who are receiving ECT, a proportion of them require ongoing ECT treatments at a frequency to be determined empirically, and that disrupts their life. They can't function for a day or two afterwards. They receive the anesthetic procedure, which in and of itself carries some risks. So if we could come up with another strategy like magnetic seizure therapy for maintenance purposes, we may be able to avoid some of these issues. And we'll look at another strategy yet similar to that. Now, I've mentioned FEAST, or focal electrically administered seizure therapy. And this is a complicated process by which spatially focuses the electrostimulus to initiate seizure activity in the right prefrontal cortex, achieving enhanced focality and using asymmetric electrogeometry and unidirectional current. And in that context, as I mentioned before, with magnetic seizure therapy, they're able to bypass the hippocampus and other related structures that are related to memory. In one open label non-randomized trial, in a small sample size of 20 people, compared FEAST to right unilateral ultra brief pulse ECT and assessed the efficacy and cognitive effects, and found no differences between the two groups. So no differences in terms of efficacy, but differences in cognitive effects were far less with FEAST. The authors concluded that a larger comparative study is indicated. So these are two new approaches which we may see on the horizon in clinical practice in the not too distant future. I'm going to switch now to TMS, but I'm not going to forget ECT, because part of my presentation on TMS is also going to describe whether or not TMS is an alternative treatment strategy for ECT, and we'll get to that slide in not too long a time. So what are the advantages and disadvantages of TMS, just as I did with ECT? I'm going to go through this same exercise. No seizure is necessary, so you don't have to receive an anesthetic agent. And in studies that have been conducted, there's been a strong pro-cognitive effect, particularly in areas like working memory and attention with transcranial magnetic stimulation. So positive, in fact, that there are now well over 100 studies being conducted using TMS as a treatment for mild cognitive impairment or for early Alzheimer's disease. I don't know if anybody's familiar with that literature, but more and more attention is being paid to that. We conducted the first ECT TMS comparison study back in the 1990s when I was at the University of Illinois, and we did cognitive testing on our patients, and we got the same kind of cognitive disruption that you would see from the literature and from other reports of electroconvulsive therapy. But we're one of the first to report not only did we not see cognitive deficits, we saw improvement in certain cognitive functions, even in the absence of improvement in mood. So we noted that in the literature. Other people became aware of that. Not too long after that, neurology picked it up, and now they're using TMS in hundreds of studies to look at whether or not it can help people with cognitive deficits. No drug interactions. You're not giving these patients any other medications as part of the TMS process. They may be on antidepressant medication, anxiolytic medication, mood stabilizing medication, but that's not part of the treatment process. So there are minimal to no systemic effects you have to be concerned about. And unlike electroconvulsive therapy, the subject remains completely independent, show up for their treatment, treatment is over, leave, drive themselves to where they need to be and go about their daily activities with no impediments, no monitoring from someone else. And patient preference. Many people have reported receiving ECT and then TMS as a course of their history of severe depression. And 80% of those patients said that they would prefer TMS over electroconvulsive therapy. What are some of the disadvantages of TMS? Well, 15 years is a lot, but it's not 80 years. So we have over 8 decades of experience with electroconvulsive therapy, where we have about a decade and a half with TMS. It's more time intensive. Instead of 6 to 9 to 12 treatments with ECT, it typically requires 20 to 30 treatment sessions, 5 days a week for up to 6 weeks. And then there's a tapering process that also goes on where you decrease the frequency of the TMS treatments so you don't stop it abruptly. And unlike ECT, but like antidepressant medication, TMS has a relatively slow onset of efficacy. So usually it takes weeks to get the benefit, whereas with ECT, for those of you who work with patients with ECT, you know sometimes 1 or 2 treatments can have a dramatic anti-suicidal effect on the patient, or can show substantial improvement in other symptoms associated with their syndrome. Application site pain and discomfort are the 2 most common side effects associated with transcranial magnetic stimulation, and rarely a cause for discontinuing transcranial magnetic stimulation. To put that in some perspective for you, all the clinical trials with antidepressant medications that were compared to placebo and ultimately approved by the FDA and are on the market now, all those medications studies, the typical discontinuation rate for adverse effects on active medication in those trials was ranged from 15 to 30%. So 15 to 30% of patients could not tolerate the treatment and had to stop the study. And it probably echoes what we see in our clinical practices as well. Contrast that to TMS, where less than 5% in the 2 largest pivotal studies that were done had to discontinue because of side effects. It says potential for seizures. What's going on here? We don't want seizures. We don't need seizures to get the benefit from TMS. Well, there is a possibility under certain circumstances that a seizure can be induced, but it's far, far less than 1%. It's 0.0007% over a course of transcranial magnetic stimulation. But of course, if it occurs in your patient, it's 100%. So people who are providing the treatments, the treaters themselves have to be trained in how to manage these patients and get them safely positioned before someone arrives from the emergency department to help with the patient. There's been no report of any subsequent or sequelae with a seizure induced by TMS in the literature that I'm aware of. Cost was a problem. As I mentioned, TMS was first introduced in 2008, and it took until about 2015 before the major insurance companies would pay for this particular treatment. I spent most of my life in Blue Cross Blue Shield and Medicare offices trying to convince them that this was an effective therapy for about 2 years before we finally won benefit this benefit for our patients. Now, every major insurance company covers it. That's the good news. The bad news is they all have different sets of criteria for who qualifies. And so you have to be aware of those criteria and you have to fill out the forms accordingly to get prior authorization, but they do cover the treatment. Out-of-pocket expenses about $10,000. In the early days, 2008 to about 2015, more of my patients paid out of pocket than they had insurance reimbursing them for their TMS. So you've probably seen a slide like this before, and it gives us some idea why we think transcranial magnetic stimulation may have a therapeutic impact, especially on depression. And what this device does is it produces pulsed magnetic fields. The strength of those fields is typical for first generation MRI devices, 1.5 to 3 Tesla. And these magnetic fields, unlike electrical current provided by ECT, for example, will pass unimpeded through skin, skull, muscle tissue to a depth of about 2 to 3 centimeters into the cortex. And in doing that, it induces a focal electrical current in cortical tissue, which not only produces local activity changes, but also distal functional changes in targeted neurocircuitry and neural networks that I mentioned before. And so the picture of the slide here shows you the most common positioning of the coil. It's over the left dorsolateral prefrontal cortex. And the reason it's put over the left dorsolateral prefrontal cortex was an ongoing imaging literature at the time that TMS was being developed, which showed that people with depression had decreased metabolism, decreased blood flow to that area of the brain. So it made sense if you could increase activity and blood flow, maybe you could reverse some of the symptoms associated with depression. Today, we don't believe that that's really the reason that TMS benefits our patients. Rather, transsynaptically, what we do at the surface of the brain is delivered to deeper parts of the brain. So in this particular figure, we see the mesocortical limbic mood circuit, the amygdala, the hippocampus, the cingulate gyrus, which form that circuitry, can also be affected. And I'll show you in the next slide in a different way what parts of the brain are impacted by TMS, aside from just the local area where we stimulate. There are a number of indications that are FDA cleared. You notice I don't use the word FDA approved. FDA approval relates to medications. FDA clearance relates to devices. And there's a clear difference between devices and medication in that the focus of the FDA on medical devices in general, not just in psychiatry, is on safety, not so much as on efficacy. And so under those circumstances, they use the terminology clearance rather than approval because they don't look at that question as strongly, but they do certainly look at it, and we'll talk more about that in just a moment. By far and away, the most common indication where TMS is used in clinical practice is for unipolar major depression, and can be used as a monotherapy or as an augmentation strategy. In the studies that were conducted, most of the patients received TMS as a monotherapy. In the real world of practice, most of the patients, 90% plus, are on medication in addition to taking TMS treatments. And it's used for both acute and maintenance purposes. And more recently, a large retrospective analysis of data indicated that it could be very helpful for anxiety associated with major depressive disorder as well. Another device called the deep coil device, which we'll talk about in just a moment, the HESED coil, has also been studied for obsessive compulsive disorder and cleared for that indication from 2 large studies that indicated benefit over the sham procedure. Another couple of studies have been done with nicotine dependency using the deep coil again and found to be helpful. And then there's a handheld TMS device, which you can put over the occipital lobe. And if you have migraine headaches associated with auras and you begin to have an aura and you put the device behind your head and you can deliver 1 or 2 pulses, that often aborts the occurrence of a full-blown migraine headache. So those are the indications for which TMS has been cleared by the FDA presently. But there are lots of studies going on in different areas and different indications. And I mentioned Alzheimer's disease and mild cognitive impairment. many other areas of neurology and neuropsychiatry, but psychiatry specifically, there are studies being done for bipolar disorder, particularly the depressed phase. There are also a handful of studies looking at the manic phase of bipolar disorder, but not nearly as clear whether TMS would be potentially beneficial under those circumstances. A lot of studies are being conducted on anxiety disorders, particularly generalized anxiety and post-traumatic stress disorders. Many of the VA centers in the country are doing studies with post-traumatic stress disorders, which is so prevalent amongst their patients. There are a variety of studies also done in psychotic patients with schizophrenia, attempts to improve depression, which is one of the dimensions of the illness process, but also cognitive function and negative symptoms. The coils are placed in a different location. The stimulation parameters are different, as we'll talk about in just a moment, than they are with depression, but they can still improve some symptoms. For example, coils are often placed over the parietal temporal juncture, right over the auditory cortex. And if you do imaging studies on these patients with treatment-resistant psychosis and auditory hallucinations, you'll see that there's more activity going on in that particular part of the brain. If you treat with inhibitory transcranial magnetic stimulation rather than excitatory transcranial magnetic stimulation, you can dampen that activity, and the correlate with that is improvement in voices, sometimes to the point of complete resolution in patients who are receiving TMS. So in the not too distant future, treatment-resistant hallucinations, negative symptoms, and depression associated with schizophrenia may also be targets and cleared indications by the FDA. I mentioned the neurocognitive disorders. In addition to nicotine dependency, other addiction disorders that have been studied with positive preliminary results include alcohol dependency and stimulant abuse, and finally eating disorders. So the field is opening up. The different types of indications are growing almost yearly, and we'll see if we get any more cleared approvals by the FDA for these indications in the not too distant future. There's one major contraindication to the use of TMS, and that's the relative positioning of any conductive, ferromatic, or other magnetic sensitive materials within 30 centimeters of where the coil is placed, because that coil is producing that very intense magnetic field that I talked about a little bit earlier. The intensity is rapidly dissolves over short distances, but within 30 centimeters, you could damage like a cochlear implant, for example, or you could heat up the materials and aneurysm clip, for example, and you could damage the tissue around it. So that's the one major contraindication. That excludes dental hardware, because most of the materials used for dental treatments are more than 30 centimeters from where the coil is placed, and they use materials that are not magnetically sensitive. So this slide goes back a little bit to showing us different areas of the central nervous system that may be impacted. This involved summarizing brain activity increases using PET studies in 23 patients who got stimulated over the left prefrontal cortex with transcranial magnetic stimulation. And any place where you see red, that's an increase in activity and blood flow. And as you can see, where the left side of the panel there, where it says TMS coil with the arrow, you can see right underneath that, there's the red patch showing up indicating increased activity. But you also see deeper structures like the mesocortical limbic mood circuitry I talked about and demonstrated in that picture just a couple slides ago, and some other networks which are far distant from these particular areas of the brain. Again, underscoring the idea that the connectivity amongst neurocircuits and across neural networks is very important in understanding the pathophysiology of depression and how something like TMS might benefit our patients. This is an early generation MagStim. It's another device, not the one that was initially cleared by the FDA. I'll show you that in just a moment. But it's good for the purposes of demonstrating the various components of all of the TMS devices. There's a cabinet, and in that cabinet are capacitors, which are capable of storing very large amounts of electrical activity. And then there's the stimulator itself, which is fine-tuned to deliver a certain set of parameters. And that's done by the line coming out of the stimulator into a ferromagnetic coil. This one is a figure 8 coil. It's encased in heavy plastic coating because, as you might imagine, a large amount of heat is generated, and so you could burn the skin if we place it up against the forehead, just the pure metal itself, so that heavy casing is there as well. And the computer program is set up to decide which parameters you want to use with the patients, what frequency you want to treat the patients at, what intensity you want to treat the patients at. And we'll talk more about that as we go through some of the discussion about TMS. This slide shows the first device to get clearance. The left side is the utilitarian one that we used in the clinical trial that was conducted. The right side was the one that got all gussied up so that it look less threatening to the patient and made it easier for the treaters to use this particular device. The other reason I like to show this is I think this is the most photogenic I've ever looked, don't you? It's not going to get any funnier. All right. This is the other major coil that's out on the market. It's called the Deep H coil, which stands for Hesed coil. And it's got air coil windings underneath this helmet-like coil, which is placed over the front and middle of the head and can stimulate to a much greater depth. I mentioned earlier that the single surface coil can stimulate to 2 to 3 centimeters in depth. This particular coil can stimulate to up to 6 centimeters in depth. So you theoretically could be stimulating the cingulate gyrus or the amygdala directly as opposed to indirectly transsynaptically by stimulating things at the surface. But the focality is lost. So while you get more depth in terms of the intensity of the field and its direct contact with areas that you're of interest in treating, it spreads out more, and that spreading out makes it less intense in that particular area, spreads to the premotor cortex, sometimes as far back as the motor cortex, and may increase the risk for seizures as a result. So it has to be done very carefully. There's lots of literature about TMS. There are at least 40 sham active TMS controlled trials in the world literature that I'm aware of, and literally 5 or 6 systematic reviews / meta-analysis. And we're going to focus on TMS versus a sham procedure with patients taking or not taking concurrent medication. We're going to talk about ECT versus transcranial magnetic stimulation. Most of those studies were single blind and open label design for obvious reasons, and without or with concurrent medication. And this data indicating that the durability of effect for maintenance purposes and long-term outcomes can also be quite substantial, in the range of 60%, patients remaining either responsive or remitted at the end of 1 year after an acute trial of transcranial magnetic stimulation. So this was data from the pivotal study. And this was what's called the indicated population, the best scenario. In that particular study, while there were 300 patients involved, 160 of those patients had only 1 failed antidepressant trial in the current episode. The others had 2, 3, or 4. And while we just missed clinical significant difference in looking at the entire sample size, the FDA was still interested enough to say, just take out the patients who had only 1 failed antidepressant trial and see what you get on the primary outcome measure, which was the MADRS, or the secondary outcome measure, the HAM-24. So the way I would interpret this slide is on the left-hand side, you see patients' MADRS scores at baseline going down. That means the scores are improving, patients are getting better. And the gray line with circles represents those patients getting the sham procedure, and the lime green line represents those patients getting active transcranial magnetic stimulation. And what you see is by week 2 of the 6-week study, there already was a significant difference favoring active TMS over sham TMS at week 2, week 4, and week 6. And the total point differential was in the range of 4 to 5 points. To put that into some perspective, that is clinically relevant, first of all. And most of the antidepressant placebo-controlled studies that were done only separated from placebo by around 3 points. And patients in those studies were not treatment-resistant depressed patients, and they were excluded from these studies. So now we had a more difficult group of patients, at least 1 treatment-resistant episode in the current episode. and much more pronounced differential benefit for active treatment over sham treatment. The same was true for the secondary outcome measure in this particular study, the HAM item 24 scale. Another way to look at this are effect sizes, and I'm sure you're familiar with this concept. Effect sizes is a statistical way of combining oftentimes multiple meta-analysis or multiple studies and to get a more clinically relevant feel for whether or not patients are benefiting to a clinically relevant degree. And typically, an effect size of 0.0 means there's no difference between active and sham treatment or active treatment and placebo. Effect sizes between 0.0 and 0.3 are usually considered not to be clinically relevant. Now, if you look at all the clinical trials that were conducted with antidepressants in comparison to placebo in non-treatment resistant patients, the average effect size was 0.31. So all the drugs we prescribe have an effect size in the 0.31, 0.35 range, which ain't good. So you wonder why our patients don't do as well as we would like them to, even though they were called responders or emitters. When you calculate the effect sizes, it gives you a much different perspective. By contrast, in a more treatment-resistant group of patients, in 2 large studies that were conducted with TMS that led to its clearance by the FDA, the effect size was 0.52, which gets us into the moderately relevant, clinically effective treatment stage. So, and further meta-analysis and further effect size calculations have actually shown it to be as high as 0.7. Compare or contrast that with ECT, which has the highest effect size for any psychiatric treatment. It's around 0.9. So just to give you some perspective. So 0.31 for antidepressants, around 0.5, 0.6, 0.7 for TMS, 0.9 for electroconvulsive therapy. As we speak, there's a lot of research and study going on. How can we improve transcranial magnetic stimulation? Can we shorten the treatment sessions? Can we shorten the entire time? Can we get more aggressive? Can we treat over the right dorsolateral prefrontal cortex? Can we treat sequentially, starting with right and going with left in a single session? Can we place the coil over the dorsal medial prefrontal cortex? Depending on imaging data, excuse me, I'm just getting over a COVID bout, so my voice is a little raspy. I apologize for that. We may want to place the coil in other areas, or we may want to place the coil in multiple areas over a course of treatments or even within a single treatment session. One thing we have to do when we decide where to put the coil is we have to take it and put it over the motor cortex. So before we place it over the left dorsolateral prefrontal cortex, we place it over the left motor cortex and we move the coil around until we get stimulations that show a contraction of the thumb or the forefinger or the opposite hand. And that tells us where we want to be located by then calculating 5.5 centimeters anterior and moving it and plopping it down. About 70% of the time we're in the range or the area that we want to be. It defines the dorsolateral prefrontal cortex, which means about 30% of the time we don't. So we can do magnetic resonance imaging, neuronavigation, or something called beam F3 EEG calculations, which get us a little bit closer, but are much more complicated to do and much more expensive. So the vast majority of patients are still receiving the 5 centimeter rule, but that won't be for much longer. We could use a deep coil, as I talked about before, to stimulate to a greater depth. But again, we lose focality, unfortunately. The number of daily sessions can also be enhanced. And one protocol called the SAINT protocol, which I'll describe in just a moment, is in a real advance in how quickly we can get patients under control. And we can combine transcranial magnetic stimulation in between TMS treatment sessions and even within TMS treatment sessions. There's a literature showing that while they're getting treated, they're more aware, they're more receptive to input. So their cognitive behavioral therapist sitting in the room while patients are getting their TMS treatment and going through a cognitive behavioral therapy exercise with them. And the preliminary data showed that there's a more rapid benefit from CBT as a result of that, and a better overall outcome in terms of patients who are receiving TMS. Various stimulus characters can also be adjusted: high frequency, low frequency, ultra high frequency, the number of pulses per train, per session, per course, the intensity. when we first started using TMS, we were treating at about 80% of motor threshold. And motor threshold defines the amount of energy the device puts out to get those contractions going in the opposite hand. And typically, most studies early on treated at 80%, 90% of the motor threshold and got inconsistent results in terms of benefit for depression. So slowly but surely, we built up to 100%, 110%, and now most patients get 120% of the determined motor threshold, which is different for each patient for a variety of reasons. So they're getting very aggressive intensities without causing further side effects. And then there's one approach which is gaining rapid utilization. It's called theta burst stimulation. Some of you may have read about it, or you may even have a device that can adapt to it. And theta burst stimulation gives us a train of TMS pulses that are interspersed with triple pulse burst of 50 hertz at 80% motor threshold, with an interburst interval of 20 milliseconds at a rate of 5 hertz. And this can be continuous over 40 seconds and usually slow frequency, or it can be intermittent over 8 seconds with rapid frequency. Why do we go through this trouble? Well, this particular approach seems to impact theta rhythms, and theta rhythms are associated with long-term potentiation and long-term depression, which are related to synaptic plasticity. And the ultimate goal with all these treatments and all the approaches that we use for depression, electroconvulsive therapy, transcranial magnetic stimulation, antidepressant medications, cognitive behavioral therapy, they all, in one degree or another, ultimately alter synaptic plasticity in a way that improves the patient's mood. The other clinically relevant issues for using theta burst stimulation is you can give much shorter stimulation periods, fewer pulses, lower intensity, and possibly decrease suicidal ideation. So this can dramatically improve clinical utilization. Today, using a standard TMS protocol, it's about 45 minutes. You can reduce that down to 20 minutes by decreasing the inner train interval, but you can't get much lower than that. But if you go with theta burst stimulation, you can get all the stimulations in less than 5 minutes. So patients can have a 3 to 5 minute treatment session, wait 15 minutes, have another session, and we'll see that the Saint protocol takes that to the nth degree. Because what it does is it delivers 10 sessions a day with 15-minute intersession intervals over 5 days. And per session, it's 1,800 pulses as opposed to the typical 3,000 pulses that you would receive with a standard TMS protocol. Treats at 90% of the motor threshold, adjusted for cortical distance from motor cortex to the dorsolateral prefrontal cortex. Especially in older individuals, the inside of the skull, unfortunately, in us septuagenarians, gets wider between the inside of the skull and the cortical tissue at the left dorsolateral prefrontal cortex, and may exceed that 2 to 3 centimeter reach that the single coil has. So you want to adjust motor threshold to make it more intense so that you can compensate for that when necessary. So you do structural MRIs on patients to decide whether or not this is necessary. The location of the stimulation is based on individualized functional magnetic resonance imaging and neuronavigational targeting. That in itself adds in about another $6,000 to the treatment course of transcranial magnetic stimulation. So it's mostly relegated to academic centers and investigational trials at this time, but claims to be about 90% where you want to be as opposed to 70% where you want to be, using the 5 centimeter rule we talked about a little bit earlier. And under these circumstances, some small studies have found that a substantial portion of patients can get better within the first 5 days of treatment as opposed to waiting 5 to 6 weeks. So again, this protocol is relegated to treatment centers, investigational, but in the not too distant future, some version of it may well be available in clinical practice. I wanted to look at the safety of TMS because outside of psychotherapy, I would make the claim that TMS is the safest treatment we have for our patients in psychiatry. And in the pivotal study, when we looked at serious side effects, there were no seizure events, no deaths, no suicides. As I mentioned before, minimal side effects, no adverse cognition. Most common adverse effects were headache and scalp discomfort. And as I also said, less than 5% of patients discontinued due to adverse effects. An NIMH sponsored trial to replicate this pivotal study, because the pivotal study was reimbursed by the device-based company and could have been at least theoretically biased in some of the way it analyzed the data and reported it, came up with exactly the same outcome. And the only thing that the device-based company was involved in was to provide the devices. They had no say in the design or the administration of treatment or interpretation and statistical analysis of the data. And they came up with almost exactly the same outcome. So the question often arises in clinical practice, I suspect some of you have heard this, is TMS an alternative treatment to electroconvulsive therapy? And the answer to that is unequivocally yes and no. Think about it for a while. Anyway, there are now at least 11 trials that have looked at acute TMS versus acute ECT for severe depression. The studies that have been conducted generally exclude patients who have psychotic symptoms associated with their depression, because it was thought from earlier studies that TMS was not very effective if patients had psychotic symptoms. People are beginning to shift a little bit on that idea, but these patients were sick enough to be referred for ECT, but didn't have psychotic symptoms. Under those circumstances, we'll look at, in the next slide, a meta-analysis of how the outcomes fared. We could look at TMS as a complementary treatment to ECT for acute treatment. One very interesting study, small albeit, was conducted in Australia by Saxby Pridmore and his colleagues, in which they took a group of patients, all of whom had severe unremitting depression, all of whom were thought to be clear-cut candidates for ECT, and they randomized them to get 2 weeks of unilateral non-dominant ultra-brief electroconvulsive therapy 5 days a week, or they're randomized to get 1 ECT treatment on Monday of the first week and Monday of the second week, and the other 4 days to get TMS Tuesday, Wednesday, Thursday, and Friday. And at the end of the 2 weeks, they showed that the decrease in depressive symptoms were equivalent between the two approaches. The only big difference was that the cognitive deficits were virtually absent in the patients getting only 2 ECT treatments over 2 weeks and 8 TMS treatments versus the patients who got 6 ECT treatments over that 2-week period. So something that needs to be followed up as, and one role that TMS could play in complementing ECT and causing less problems. The other is, could TMS be a potential maintenance strategy after a successful acute trial of ECT? And the answer to that is maybe. There are several studies that have been conducted now with somewhat mixed results. We still need time to decide what's the best frequency for patients, how many treatments they should receive, and what time frame to replace ECT maintenance treatment. So there are several systematic reviews and meta-analysis that look at the data comparing TMS to ECT as more trials came on the market, came on the literature. One of the largest looked at 7 randomized controlled trials involving almost 300 patients with major depression. The average number of TMS treatments was 15. The average number of ECT treatments is 8.2. 8.2 ECT treatments is just about right. 15.2 TMS treatments is only about half the number we provide for most patients in a standard protocol. So already these studies were biased against TMS by not giving it a robust trial of 30 treatment sessions. ECT was found to be superior to high-frequency TMS, remission rates being 52% with ECT versus 34% for TMS. And then there should be response rates. The OR ratio is 0.46, favoring electroconvulsive therapy. Remember, these are patients who had not benefited from any other treatment, multiple treatment trials, medication, psychotherapy, their combination, who were referred for ECT. 33% of them, a third of them, did benefit from TMS under these circumstances. And when you look at other data where more robust trials of TMS were used, that 33% goes up to more like 40, 45%. So what I would say is that if we could figure out which patients would really benefit from TMS as an alternative to ECT, somewhere around 30 to 40% of patients in clinical practice today could be treated with TMS, which carries with it far less risk than electroconvulsive therapy. The big problem is how we tease those patients out. Unfortunately, we don't have good biomarkers, whether they be genetic, neuroimaging, neurophysiological, to characterize those populations. In this particular analysis, there were no difference in dropout rates. They suggested that future trials include larger samples of patients, especially those getting TMS, better matching baseline levels of pathology, longer follow-ups, and more intense use of TMS stimulation. So you're getting the feel that TMS can be an alternative to ECT, but not in all patients, maybe not even the majority of patients. So to summarize the data thus far with TMS compared to ECT, it can produce a similar efficacy to ECT in selected patients. Just how we select those patients is a big question. TMS may be an alternative and safer way to induce seizures, magnetic seizure therapy, which we talked about. TMS may complement ECT during an acute treatment trial. TMS may be a maintenance strategy for acute ECT. Serious adverse effects with TMS are rare to absent in contradistinction to electroconvulsive therapy. I'm going to briefly talk about transcranial low-intensity electrical stimulation, of which there are two types: direct electrical stimulation and alternating stimulation, and briefly say a few words about transcranial pulsed ultrasound, and then open it up for questions. Transcranial direct current stimulation, as I mentioned before, probably has the largest literature because it's been around for decades, but has no clearance or approval per the FDA. It delivers weak electrical current to the cerebral cortex through small scalp electrodes. Anodal, cathodal can be done, which means that the direction of the electric flow goes from cathodal to anodal or from anodal to cathodal, and typically at intensities of 1.2 milliamperes for 20-minute durations. And as I mentioned earlier, it can be supervised via telemedicine format in patients who are under the direction of a physician. Or if you're really cheap, you can go out, you can buy a battery, a car battery, you can buy 2 wires, you can buy 2 electrodes, you can go online and follow the instructions and give it to yourself. That's how easy it is. And under those circumstances, there's the evidence that TDS can be effective in treating depression and may benefit other conditions such as bipolar disorder, Parkinson's disease, and schizophrenia. There just isn't the incentive economically to do the definitive study that would allow us to market this particular approach for our patients. These are some of the devices you can get online. What they all look like there, it's just so happy, angelic. And in 6 randomized controlled trials, 96 getting active, 80 getting sham DTCSF. Active was superior to sham with an effect size of 0.7. But a meta-analysis done on all the studies that were met criteria for the analysis did not find significant difference between active and sham DTMS for response and remission rates. So you saw improvement in scores, but you didn't necessarily see improvement in response and remission. And as we know, response is not adequate for most of our patients. We really have to push your treatments to remission rates. And as a result of that, if DTCS is helpful for depression, it's probably going to be milder forms of depression. Transcranial alternating current stimulation is a weak current, just as I showed with direct current stimulation, with a sine wave pattern to the scalp, which renormalizes alpha oscillatory brain activity to the left dorsal prefrontal cortex, with limited evidence for treating depression. One small study found that 10 hertz TACS was better than 40 hertz TACS or active sham. But again, this is very preliminary data, far more data with the direct current stimulation I talked about just a moment ago. And then finally, maybe the future. I talked about depth and focality. Most of the coils can be quite focal, but they're very superficial in the area of tissue that they impact. The deep H coils can be much deeper, 2 to 3 times deeper, but very spread out, so not focused on a particular area of tissue. Not so with focus ultrasound. So if we look at some studies looking at using a device that you can get again on the market, and if you can figure out where it sits in the planes, you see that small area in the central nervous system, the deep area, that's all they're stimulating. There's no transsynaptic effects. There's no superficial effects. There's no non-focality as with deep TMS. In very specific, very limited areas of tissue. And as we become more aware of those parts of the brain that are in need of changes, whether it's excitatory, inhibitory. We may be able to use ultrasound stimulation as a way of getting to those parts of the brain much more efficiently, much more effective. You're not going to see this in clinical practice for a while. There are some safety issues associated with it, but it may be available to us in the not too distant future. This slide just shows all the different devices and their indications that are available on the market per FDA approval. And this is a book that we published a few years ago for the American Psychiatric Association Press. If you're interested in reading more about transcranial magnetic stimulation with shameless self-promotion, I would encourage this textbook. That's my story, and I'm sticking to it. So, Dr. Singh, do we have any questions? Or did I put everybody to sleep?
We do have some questions. We can transition to the Q&A part now.
I'm going to stop recording for this.
And then